Welcome, everybody, to today's Penn AI Tech webinar. Penn AI Tech is the Penn Artificial Intelligence and Technology Collaboratory for Healthy Aging, an initiative funded by the National Institute on Aging. Today, we're very happy to have with us Dr. Barbara Barbosa Neves, who is an award-winning sociologist of aging and technology. Her research bridges gerontology and computer and social sciences, and Barbara studies how emerging technologies such as robots, virtual reality, and AI affect social health, particularly loneliness, isolation, and inequality in later life. Her mixed methods and co-design research aims to ensure technologies foster inclusion rather than marginalize people 65 years and older, especially those living in long-term care settings. She's an associate professor and inaugural Sydney Horizon Fellow in AI and Healthy Aging at the University of Sydney, where she leads the AI social science team at the Sydney Centre for Healthy Societies. And she's also an incoming Australian Research Council Future Fellow, one of Australia's most competitive research awards. Prior to moving to Australia, she was Associate Director of the Technologies for Aging Gracefully Lab in the Department of Computer Science at the University of Toronto, Canada. I want to remind our attendees that you can use the Q&A feature if you have questions for our speaker. This presentation is being recorded and we'll have a chance for Q&A afterwards. Barbara, I'll turn it over to you, and I want to thank you because you're joining us from Sydney, and in spite of the time difference, you're joining us in the middle of the night for you, so we're really appreciative to have you here with us today.
Thank you so much, George. My pleasure. I'm going to share my screen. Here we go. Here we go. Can you see my slides?
Yes.
Perfect. Thank you so much. Hello, everybody. Good morning, good afternoon. Thank you so much for having me, and I really appreciate this invitation. And thank you all for joining us today. I was supposed to be traveling, but sadly, I wasn't able to travel, so I'm coming to you from the future. It's 2 a.m. in Sydney, and we're still all here. And I also wanted to note that I'm recovering from a nasty cold, so my voice is a little bit raspy, so apologies for that. As I mentioned, I'm coming to you from Sydney, and Sydney is the land of the Gadigal people of the Eora Nation, and I would like to pay my respects to elders past and present and all First Nations. So this is a customary acknowledgement of country that we do in Australia. Now, as George said, I'm a sociologist of aging and technology, and I've been studying for many years, first in Canada and now here in Australia, how we can design and implement better emerging technologies for older people that is actually with older people, so that does not exclude older people from the process, from the design and implementation process. And this is something that I really need to emphasize because it is a common thread that you'll see throughout what I'm presenting today. So I am part of the Sydney Centre for Healthy Societies, and my research has been funded by the Australian and the Canadian Research Councils and by both governments. So this is just something that I need to disclose. So I have conducted several studies on various emerging technologies from mobile apps that we co-designed with aged care recipients. So in Australia, we call long-term care recipients aged care recipients. It's just a different terminology. And so we co-designed apps with older people living in care, especially those living with frailty and complex needs. But we also focused on social robots and virtual reality. But with the rapid advancement of social AI, social artificial intelligence, especially since 2022, my focus has been more on AI systems and social health, which, as George mentioned, includes loneliness and social isolation. So for today's conversation, I really wanted to bring together some of my recent AI projects to highlight the issues that I think are critical to consider. So I asked DALL-E to generate an image of myself and my work, and it's not bad. But if you look closely, the older men look like twins because all older men look alike. And the only reason we see some diversity here at all is because I asked for it, though even the robots are white. And these default assumptions might seem small, but they matter for sociologists and social gerontologists because they shape how aging and care are imagined in AI systems and what kinds of futures are considered normal or desirable. And so for today's webinar, I'm bringing together several projects to kind of highlight that thread of what is considered a normal and desirable future. And so we find ourselves at a particular moment in time. On the one hand, AI-driven recruitment platforms are facing lawsuits for discriminating against older applicants, sometimes as young as 40. And these tools were automatically removing job applications based on age. On the other hand, we see daily media headlines celebrating robots as solutions to solve the crisis of an aging population, alongside multi-million-dollar investments in chatbots that promise to cure loneliness among older people. And again, these stories might seem disconnected, but for us, they're always linked. They are closely related because they reflect how aging and later life care are constructed as urgent problems that can only be fixed through new technology. So the context for my research is the so-called crisis in long-term care, which in Australia, as I said, we call aged care. And this sector has been struggling with staff shortages, substandard medical and social care, and alarming levels of health issues, social health issues, such as loneliness, which affects up to 61% of aged care recipients. And loneliness is something that is quite emotionally painful, as can be seen by the words of my participants. They feel forgotten, invalid, they cry themselves to sleep, they are just waiting to die. And loneliness is also a major public health issue linked to cognitive and physical decline, to cardiovascular disease, to stroke, to a 40% higher chance of dementia, regardless of genetics or background. And so loneliness has been finally recognized as an emerging public and social health issue across industrialized societies. In 2018, for example, the UK government appointed the world's first Minister for Loneliness, followed by Japan in 2021. In 2023, the US Surgeon General named loneliness a public health crisis, and the WHO, the World Health Organization, started in 2024 a commission to tackle loneliness across the world. And so, given this context, and to respond to all of these issues, governments and tech companies are promoting AI, from robots to smart assistants, as solutions to fix care. Now, I should just note here that I approach AI from a very specific social science perspective. Many researchers conceptualize AI technically in terms of autonomous systems or machine learning or LLMs, large language models, or natural language processing. But for us, AI is shaped by human decisions and social values as well. It reflects the data that it is trained on, the goals set by the designers, the values of the society around it, as well as how and where it is used. So for sociologists, AI is not just technical, it is social, political, cultural, and material. And this is important because for us, AI is influenced by social political choices, cultural values, and material resources. And so we call AI a socio-technical system, not just a technical system, a socio-technical system. And so I wanted to share with you today results from 3 studies to show that common thread that I mentioned at the start, which I think is essential for discussions around aging and AI. So I'm bringing together 3 different studies. The first study, conducted with my colleagues at Monash University, also here in Australia, aimed to understand aging perceptions and representations of AI in for long-term care. And so that study involved different stakeholders, from AI developers just developing technologies for later life care, care staff, advocates, and recipients. We conducted surveys with providers, with care providers. We interviewed diverse stakeholders, including AI developers and aged care staff. And the study also included a participant observation component in care homes and age tech conferences. So age tech conferences are conferences where age tech companies usually show, display their products. And that ethnographic component means that we were observing how people interact with and talk about technology and aging. And the team brought expertise in sociology, gerontology, computer science, and bioethics. So what we found across our data was what we called promissory discourses. So this is already a concept that has been used in the field. And so we just use that concept to make sense of our data from an analytical and conceptual standpoint. And promissory discourses are narratives that assure us that certain positive outcomes will happen in the future. And we found these promises around three main areas. First, social connection, especially in relation to loneliness and social isolation, then monitoring and detection, fall prevention, sensors tracking unusual behavior, and so on, and then clinical uses, pain assessment, medication assessment, diagnosis, and so on. To give you some examples of those promissory discourses, one of the promises was hope in relation to social connection. Developers saw AI, like smart voice assistants, chatbots, and robots, as answers to the rising loneliness and social isolation of residents. AI promises hope to address social issues, and for example, in the words of Camille, an AI developer that we interviewed, and I'm here using pseudonyms that were chosen by our participants. So Camille told us that AI can bring in some hope. Most of them, residents, end up in being in a bed or in just a room, and very few of them will have the mobility to move around and talk to people. When they reach the residential aged care, what happens is that they know that this is the end of their life. One thing that we can do is to keep them connected to their loved ones and let them continue that social thing that they were having. In terms of monitoring and detection, the promissory discourse here was around time. All stakeholders shared common promissory discourses about how AI would automate tasks, allowing staff to increase their time with residents. Staff and advocates mentioned how smart documentation, tracking and fall prevention technologies, and smart systems to lift residents could help with this. Their focus was on how AI can be used to automate such tasks so that it frees up their schedules for more individualized care. For example, Ken, a founder of a big data analytics company, developed an AI technology for long-term care here in Australia, inspired by his wife, who passed away of illness in a care facility. And the technology, according to him, uses smart voice assistants to monitor medications, mood, and falls. According to him as well, the technology's potential is huge to assist staff because it gives them more time with residents. We weren't able to actually test this technology because it was still in a prototype stage. And so what we can rely on here is the information that Ken gave us during the interview. Another interesting promissory discourse was around interoperability. And here we saw opposing views. So AI developers really emphasize the ability of AI to automate tasks while communicating with other care technologies in the care home. However, for staff, developers lack knowledge of systems in care homes. Some of our interviewees said that AI developers never been to a care home, so they don't know how this works, how other types of technologies are in place, but also the problems that we have in terms of even infrastructure. And so it was interesting to see those opposing views in relation to some of these promissory discourses. In terms of the clinical uses, those promises were around objectivity and effectiveness. And this was around particularly technologies that could help with diagnosis, but also specifically for people living with dementia. For example, Gary, one of the AI developers that we interviewed, mentioned AI is not there to remove the need for a clinician. What it is there to do is to remove some of the laborious tasks that people need to undertake to give objectivity to particular assessments. Interestingly, when we asked our AI developers about algorithmic biases, if there were biases in the data sets, they all dismissed those biases, noting that we just need more data and people to use it repeatedly, and those issues will be solved, according to our AI developers. Staff and advocates were much more critical about promises of hope, objectivity, effectiveness, sharing concerns about care, reliability, and accountability, namely through questions such as the ones I have here on this slide. Will AI dehumanize care? Who is responsible if the AI malfunctions with really vulnerable populations? Something interesting that we found across the data was that while all our participants, from the developers to the staff, were really passionate about their work, they really displayed stereotypes about older generations, from distrust or inability to use technology to biomedical representations of aging that just reduced people to their illnesses. And so, to give you a few examples, for example, Mark, one of the AI developers, mentioned older people, they've been brought up in a generation with stupid sci-fi movies and books that always paint a negative picture, and that is bad. Kathy, a staff member, nurse, mentioned the older generation doesn't like technology. And finally, Sam, an advocate, mentioned during the interview that aged care generally gets staffed with the older generation of carers, and change management is difficult to do. Younger people are always open to new ideas. So the assumption here is that older people are not. We were not so surprised to see some of these ideas and stereotypical assumptions amongst AI developers, to be honest, but we were a bit more surprised to find them so clearly amongst care staff and advocates, even though, again, all stakeholders were really passionate about their work. I also conducted, as I mentioned, an ethnographic component at Age Tech conferences, and this particular one was an industry digital health and Age Tech conference in 2024 that brought together 8,000 attendees and over 150 startups. And I was there presenting my work and observing how companies and health stakeholders talked about older people and later life care. And I found exactly the same scripts regarding promissory discourses, as well as this idea of aging anxieties, the concern and fear with an aging population. And so within that sense of concern and fear, the only possible solution was technological. As mentioned by one of the age tech CEOs who spoke at the conference, AI is the future of the elderly. They are all lonely, and there will never be enough humans to look after them. And so I'm sure that by now it's not surprising that we are seeing some very ageist assumptions across our data. Older people were always seen as all the same. They're passive, they're technophobic, they're homogeneous. And so aging is always perceived as a cost, as a problem that we need to fix. It is a reminder that ageism, stereotypes, discrimination, and prejudice based on age is not only enacted by design, but also by implementation and use. And we are, of course, extremely worried about ageism because it's not just hurtful and discriminatory, but it also has real consequences for health, well-being, and the economy. Research shows that it affects people's life expectancies, increases depression and healthcare costs, and leads to major economic and social losses when older people are excluded from work and from society. And so this study was the first study that we conducted trying to understand those representations and how different stakeholders think about older people in care. And that led me to the second study as I wanted to further understand the discourses of age tech companies regarding aging, age care, and AI more generally. And so, with a multidisciplinary team from the University of Sydney, we focused on the websites and on the material promotional aspects and products of companies selling AI for later life care to explore how older people and care were represented on the websites, but also on those promotional materials, description of the products, and so on. So what we did was we collected data from all companies listed in the top 100 most relevant results in 2024, found through a Google search in English. We excluded sites not marketing their own products or services, and we ended up with 33 companies. Companies were in Australia, New Zealand, Canada, the US, Hong Kong, Malaysia, Singapore, Finland, Germany, Greece, and the UK. And the services or products that they were selling were mostly care bots, chatbots, sensors, decision-making systems, and smart clinical apps, even though I should note that sometimes their specific AI capabilities were frequently unclear. As AI became a buzzword, we also found that a lot of companies use AI, but they don't really specify what kind of AI they are selling or offering. And so, to analyze the textual and the visual data of the websites and commercial materials, we used a multi-tiered mixed methods approach that combined content, thematic, and semiotic analysis to investigate how companies represent older people, define user needs, and construct dominant narratives about technology and aging. And so we've identified a few recurrent discourses across the visual and textual data. The first one was the sense of what we called a carification of aging, where aging is presented mainly as a condition that requires constant care and monitoring and management. Aging was linked to vulnerability, rising costs, growing risks, and mounting pressures on societies. The message was that the current care system is inefficient. Problems in long-term care were always framed as technical problems. They are problems of data, of coordination, of efficiency. And so the challenges of care were therefore redefined so that the only possible solution was AI. To support this idea, care itself was portrayed as something that needs to be measured and tracked. And they used images of dashboards and monitoring systems and real-time alerts. And older people appeared only at the margins or as data points on the screen, or those disembodied, wrinkly hands reduced to indicators of fragility and risk. We also found, of course, this idea of datafication of care, that everything becomes or is a data point that we need to measure and manage. Then from that study, I really wanted to go deeper into one particular AI system to kind of understand those discourses, not just those discourses, but how they are then informing design. And we decided then to look at fall detection and prevention technologies because these AI-driven technologies have become quite popular in Australia, but also overseas. And I had observed in care homes when I was doing my ethnographic work. So usually I stay in a care home for 3 to 6 months just to observe how people interact with technology. And what I saw during some of that ethnographic work was that, particularly in relation to AI fall detection sensors, was that there is always a huge number of false positives. There's constant false alarms. And that leads not only to staff ignoring or turning off the sensors, but also to residents learning to move around the sensors, often with their walkers, to kind of avoid triggering the technology. So it was interesting that I realized that we actually working for the technology, not the other way around. And so falls cause debilitating injuries, including hip fractures, brain trauma, and they lead to further health decline. The severity of falls has driven attempts to find technological remedies, both to prevent and to detect falls. And this is, of course, a critical issue to address in long-term care. And so our analysis was not to discount the importance of these sensors and the importance of the problem of falls. So when we started examining the data sets, large data sets that are used to train fall detection models, we really wanted to understand which data are included, which variables are used, and how the older body is categorized. And so we analyzed 6 large data sets so far, and this is what we found. We found that the variables collected are movement variables, with people appearing in the data as points in space and time separated from the bodies that generate the movements and the contexts in which the movements take place, for example, a care home. These models use volunteers, usually students, so young people, who fall on purpose so they can measure all the angles of the fall. And thus the data is collected with young people who fall, likely fall in different ways to older people and who do so in artificial circumstances. What we found is that, of course, then older people were mostly absent from the data sets. And so across all our studies on AI, what we found is that despite this idea that AI holds great promise for improving care for older people, as long as it does not exacerbate ageism or introduce ageism, what we see is that unfortunately we are not there yet. As I said, if we look at all the data and all the studies that we've done so far, aging continues to be framed as solely a demographic and economic problem, while care is reduced to efficiency and cost. Ageist assumptions portray older people as dependent, as passive, as technophobic, as resistant to change, as not open to new ideas, which in turn contributes to their exclusion and underrepresentation in AI data sets and in their deployment. When they are included, it's always the younger, healthier cohort. And since access to data with vulnerable populations is, of course, hard because of ethical issues, developers also rely progressively on synthetic data, which is AI simulated data, which is once again decontextualized from the everyday realities of care recipients. And like gender or race, age-related biases remain overlooked in responsible AI guidelines and governance. And as captured in our studies, I think this is important to emphasize. It's not enough just to fix age-related biases by adding more people to data sets or by focusing only on AI developers. We also need to look at the care system and society at large. At the same time, and I want to also provide a positive perspective, at the same time, our research shows that AI can be beneficial for some older people in care when implemented appropriately and contextually. I observed older residents using voice assistants to maintain a sense of agency and dignity in their everyday lives by turning the lights on and off, by checking the weather, by asking for a song, by requesting particular news, and so on, without having to constantly rely on a staff member. And so that brought them an interesting sense of agency and independence in care. And so I would say that we face major challenges for aging and caring futures. Older people remain excluded and underrepresented across data sets, design, and implementation, which raises, of course, important issues of inclusion, equity, and social justice. At the same time, we must support agency and dignity in later life while building sustainable and inclusive long-term care systems for a growing aging population. As we know, for the first time in global history, there are more people, so older people age 65 and over, than children under the age of 5. And this raises questions about how to rethink and redistribute care in sustainable, fair, inclusive, and intergenerational ways without forgetting that older people also care for themselves and for others, even when they are frail and even when they are in care. And that aging is also an opportunity and an achievement. And so I think it's really important to have that very balanced way of understanding aging and care. So, what I'm arguing here is that we need to move beyond seeing AI as a quick fix for a long-term care system in crisis. We need to instead use it to find ways of integrating human and tech-based care that kind of redresses the inequalities and the simplistic biomedical models that reduce older people to a disease and a cost. In a lot of our interviews, for example, with AI developers, but also clinical staff in care homes, older people are always represented it, as I said, through diseases. We don't use this expression anymore, but it's an expression that our interviews use. They are demented, or it's always reducing someone to their illness only. And so what I'm trying to argue here is that for that to reimagine AI, human care, and aging futures, we need to co-create care communities that are intersectional, that are intergenerational, that are inclusive. And we can't, of course, ignore the elephant in the room. AI itself is resource hungry. Training and using large language models, LLMs like ChatGPT, consumes enormous amounts of electricity and produces significant carbon emissions. So any vision of fair care futures must be ecologically sustainable too. And so in this context, I'm taking a particular approach in my program of research that recognizes these costs and aims to ensure equity, dignity, and balance across social and ecological worlds. And so I call this a regenerative sociology or gerontology approach. And this draws on regenerative design and development that already exists. I did not coin the term. And this approach tries to see regeneration as sustainable renewal and restoration of social ecological structures. And so I'm trying to, in my new work, bring together those elements to rethink care futures in a way that accounts for socio-ecological structures as well. For that, I am establishing a transformative community of care futures that brings together key care stakeholders, including providers, staff, recipients, caregivers, advocates, AI developers, policymakers, different generations. So we have young people in the community as well, and ecological delegates to rethink care systems in ways that support fairness, respect people's dignity, and promote social and environmental systems that are sustainable but also empowered, that can thrive. The issue here is not just to see if we don't affect the environment or other social structures. The issue here is, can we actually design something where every single human and non-human actor can thrive? Is that possible to attain? And what I'm trying to contend is that that is possible if we take a concerted participatory approach that, first of all, rejects the one size fits all, considers the diversity of little life, that older people are very heterogeneous, they have different needs and desires and aspirations, that really takes co-design seriously, co-creation seriously, and not as a token consultation when decisions were already made. I see that a lot. Sometimes co-design processes, at least here in Australia, and sometimes also in Canada, I could observe that, are designed in a kind of a consultation way. The designers already made the decision, the technology was already developed, and so we're just going to ask other people if they like it. And that is not really co-design, that's a consultation process. I'm even advocating for what we call a comprehensive co-design. When we co-design technologies with for our participants, we found that just focusing on the end user is also not enough. We need to account for the whole network of care and include family, staff. Otherwise, what we can might risk is that by focusing on only one group, we actually forget that people do not interact with others in isolation, that there is an ecosystem of care that we need to consider. For example, we also co-design technologies that are really useful for the residents, but they are very onerous for the staff members. And so we need to take into account how those different actors and networks can benefit from the co-design process. And finally, we need to change techno-solutionism, this idea that technology is going to, in isolation, solve all our social problems. Loneliness, for example, is a very complex problem. Loneliness relates to this subjective feeling of lacking companionship, of missing meaningful relationships, not just about social interaction, it's about meaningful social interaction. So we can have a companion robot or a chat bot that tries to converse with someone. Conversation and interaction is not enough. We need meaningful conversation, and we need to understand that the simulation of that conversation can also be a problem. And so we need to recognize that care is relational, that it is both social and technical and personal, and that it requires a whole ecosystem of care beyond one technology or one technological feature. I wanted to close with and to end this presentation because I want to make sure we have enough time for questions with the voices of older people themselves. We just asked 136 of our current participants what they think about AI and what they want from AI. And their message was clear. They want to be recognized, they want to be included, and they want to be respected. For example, and these are just some of the comments that we got, so older people, what we think still matters. And with advancing technologies, we are living longer and we are a growing generation that can still contribute greatly. Don't pass us off as not mattering. Don't assume all elderly people don't understand modern technology and have more patience to explain. Ensure equal access so no one misses out. Assist us, not control us. These comments remind us that the future of AI in care must be designed with older people, not just for them, but as we argue, with their communities as well. And that is something that I think is really important. I am looking forward to your questions and comments. I just wanted to mention that this research is available online, open access, if you like to read and comment. And we also published a media piece in the conversation, and this work was recently included in The Guardian. And so thank you so much, and I'm looking forward to your questions and comments. Thank you.
Thank you so much for this wonderful presentation. Just to remind folks that you can post your questions using the Q&A feature, and I know several people have already done this. I'll start with one of the questions from the chat. People have been talking about how they've enjoyed your presentation. One question has to do with how your work has informed or can inform national policy and legislation. And please share some of your tactics going forward in that space.
Thank you so much. That's such an important question. Indeed. So what we do usually is we include policymakers in all our projects as well. And that helps us with translating and mobilizing the findings. As we know, informing policy is actually very hard. But I think with strategies in terms of including policymakers in the studies helps us understand not only their concerns, but also their challenges in the policy realm as well. And I think that's really important. In terms of informing AI developers more directly, we also have companies who partner with us that are open to the findings. And so we find that if we create a community or a community of practice that is actually based on an understanding that we're trying to find common ground that benefits different people, different stakeholders. I think there's more openness to it. Of course, it is a challenge for everybody, and I think a lot of us who work across social sciences, gerontology, health, and computer science feel that it is still a challenge. But I think that involving policymakers from the inceptions of your projects is also a good way to address some of those challenges because there's a different openness and a different way of thinking about how can we actually then take this to policy and what kind of research do we need to take this to policy. I'm very lucky in the sense that I've been leading several evaluations for the Australian government, for example. And so that allowed me to develop skills in terms of understanding their concerns and how they think about policy and impacting society, which sometimes is very different from how we academics think about policy and impacting society. And again, that openness to learn from others. Academics are experts in a particular realm, but we have to be very open to other experts, and that includes experts with lived experience, so from policymakers to older people. I hope this answers the question.
We had a question. There's a comment about how AI developers have in the past failed to recognize the needs and preferences of their end users, and more specifically, older adults, that oftentimes solutions are designed without any feedback. And even though, as you also mentioned, older adults are first and foremost people, with every person being different, and just being an older adult does not necessarily mean that you represent a problem or a pathology. We've seen a lot of the startup companies, at least here in the US, a lot of technology solutions that come and go, and they often fail because of that reason that they didn't take the end users into consideration early on. Do you see that changing over time as we see more and more technology permeating all aspects of healthcare, or do you still think that is a significant challenge in this space?
Thank you so much. Really important question. I think it's still a significant challenge, not only because a lot of tech companies and AI developers have a very stereotypical idea of the user, but also because they are usually young male engineers with a very particular understanding of the world, sorry. For example, just to give you an example, a lot of the companion robots, the social robots that we test, when we actually look at the history of that robot, a lot of the robots were developed for children first. And so what happened was that the tech companies realized, oh, wait, there's this kind of interesting market here with a growing aging population. And so let's repurpose the robots for older people. And when we test some of the robots, our participants say, well, we don't like them. They are infantilizing because they were by design. They were designed to be for children. And so I think a lot of companies still struggle to understand the importance of co-design and co-creation. When they do co-design or co-creation, it's a focus group. It's not co-design. It's that I've came up with a solution, and now I just want to check if people like it. And that is not co-design. So I think we need to really continue to emphasize the importance of co-creation with older people, diverse groups of older people as well. And I think it is a challenge that we're going to see eventuating for the next years as well, especially because, again, there is no real authentic understanding of co-design. But what happens sometimes as well, and I saw this with some projects that we conducted where we were collaborating, and I worked in computer science as well. So I was working with computer scientists and developers. And it was interesting that even when we tried to define and include co-design from the start of the project, from the inception, there's always a power relationship in the sense that we then decide from all the feedback that we got from our participants what we're going to actually act upon, what we're going to select. And we saw that, and I saw that with people living with dementia, projects with people living with dementia. Developers would say, oh, I like this particular some like this particular sentence or this particular part that a respondent or an interviewee mentioned, but I'm going to discount all the rest because it doesn't interest me. And so there's like this kind of very selective understanding of co-design. We're just going to pick and choose what kind of validates what we thought we're going to be designing. And so I think it is an ongoing battle to ensure that there is a real understanding of co-design. And this is not just with tech companies or AI developers. Academics do it as well. A lot of academics also use co-design because they also became a buzzword and they use co-design in a way that is actually not co-design. It is, as I said, consultation or a short focus group, and that is not co-design. So I think again, it is a challenge that we will need to continue to address.
Another question has to do with whether any of your work has examined the use of virtual reality and/or augmented reality technologies to promote aging.
Thank you. Um, we conducted several studies on virtual reality in particular with people living with dementia in nursing homes, in care homes, but also with older people living in the community. And those studies were led by my colleague, Professor Jenny Waycott at the University of Melbourne and Professor Yvonne Miller at QT in Queensland. And we conducted different projects and then we kind of brought them together to find those similarities and differences. What we found is that, as with all technologies that we study, depends on the context. Sometimes it can be very valuable depending on how they are implemented, how they are used, but they also bring a lot of challenges. Again, they do not work in isolation. Our focus was mostly on well-being, loneliness, social isolation. So our focus was more on how to develop and use virtual reality, VR, to enhance opportunities for meaningful social connection with others, but also to address issues with boredom and well-being in care homes. We found again positive outcomes for some groups of older people, not for all. For people living with dementia, the particular types of dementia that lead to hallucinations, for example, and some virtual reality environments were not the best. We also found that it's quite onerous on the staff sometimes to set up the VR, to troubleshoot problems, to have that kind of one-on-one support. And then we found more physical dexterity issues. For example, the head-mounted display was a bit heavy for some participants. Some participants had vertigo. And so it is a technology that you still need to be in place to assist. It's not a technology they kind of live with, you can live it with the care staff and then just walk away. It requires a lot of human involvement throughout the process. But we found really positive outcomes in terms of sense of connection to self, but also to communities. For example, in one of our first studies, we were testing different environments, oceans, mountains, games, and we were also using Google Earth. And a lot of our participants wanted to use Google Earth and go and see where they lived when they were little. They wanted to go and see different countries, but they also wanted to connect to their own roots. So a lot of our participants in Australia are from migrant backgrounds. Australia is a very multicultural society. And so a lot of people wanted to go and see their places in Italy and Greece where they grew up. And it brought them a sense of connection to their past that, of course, increased their levels of well-being, but also created more opportunities for different conversations with family members. They had different things to tell them. What we realize in care homes when we interview people and when we do our ethnographic work is that because the life in a care home is so standardized, we even use this term that comes from American sociologist Irving Goffman, which is a care home becomes a total institution. Everybody has to have breakfast at the same time, lunch at the same time, dinner at the same time. All the activities are hyper standardized. And VR disrupts a little bit that standardization because people can pick what they want to do. They can pick their own environments and can be more personalized. So I think that brings some diversity to their everyday lives, but also brings about new topics of conversation with the family. A lot of my participants say it's hard to talk with family sometimes because they call or they visit and they ask, "What have you done?" And they're like, "Oh, the same. I watch TV. I went to the crafts." There's not a lot of things to talk about. Whereas I think VR gave them different experiences that led to different topics of conversation. So again, it can be very positive and negative depending on the context, depending on how it is implemented and how it is personalized and so on.
Thank you.
Thank you.
In your work on AI products, did you find any differences across locations where the companies are based, or any other observations about cross-country differences?
Thank you. That's such an important question. So much for raising it. Indeed. So, because in some countries, for example, Japan, there's a higher social acceptability of robots. The way that sometimes the materials were depicted were a little bit different because of that cultural nuance. And so, for example, robots were always seen as a kind of a family member, whereas for more Western companies, robots were still seen as a tool, a companion, but a tool. So there were some differences in terms of language that they were interesting to explore, but they were minimal in terms of we didn't find a lot of big differences, but we did find those sometimes nuanced cultural differences in how the robots were positioned in relation to care, but also society at large. Because again, in Japan, really high levels of social acceptability of robots that changed a little bit the semiotics and the semantics that were used in the commerce. But that was the only difference that we saw, and it was particularly with Japan. It was interesting because we were assuming that in more Asian societies, a lot of the discourses would be a little bit different because of filial piety. So they have a different respect and understanding of older people in their societies. But actually, we didn't find those elements so clearly in the promotional materials, which was interesting for us. Thank you.
We have a comment about the excellent presentation and how impressive it was to get insightful quotes from older adults that you incorporated in your studies. So the question is a methodological one. From a study design perspective, when conducting interviews with your participants, did you use a structured interview guide with predetermined questions or semi-structured approach, or were you completely going in with open-ended questions? It would be interesting to learn more about how you elicited such rich and meaningful feedback from your participants.
Thank you so much. So we use a multitude of methods. A lot of our studies don't rely just on one interview. We do always more than one interview, so it's more of a longitudinal qualitative understanding. We use mostly semi-structured interview guides. So we have some questions that we really want to ask, and then it's open in terms of prompts that we can add and so on. We also been doing lately what we call a featuring activity. Instead of just having an interview guide, we have a few prompts and we ask older people specifically about their ideas of the future. We ask them to think about themselves in 30 years in terms of aging. What it would be like to age in a society that is in the future, 2050. And that actually elicits a lot of interesting conversations about the future that is based on their present. And so that requires a lot of openness to sometimes let go of the scripts. But we do have, of course, for comparison, to be able to compare across participants, we do have, that's why we use mostly semi-structured interview guides. We do have questions that we ask everybody, but we are open to having different prompts and follow-ups and so on. And that is because even when I'm just studying loneliness and I'm asking people about that loneliness, because there's so much stigma around loneliness and older people in care, they already feel so stigmatized because they are old. They see themselves as frail and as dependent. They don't want to talk about loneliness. And so this happens a lot. I go and I interview them and I ask them about loneliness and feelings of loneliness. And they start by saying that the family visits often. And then it's in the second or the third or the fourth interview that they say, well, actually, the family doesn't visit that often. They only come for Christmas and for my birthday because they're very busy. And yes, I'm extremely lonely, and this is what I feel. So in the first interview, it's actually even hard to get to how they feel. We need to establish rapport, trust with our participants, and that takes time. And even for qualitative work. So for us, one interview is usually not enough. We have to have a series of interviews and different interactive ways of communicating and kind of capturing the ways that they see the world as well. Because again, our participants are extremely frail. They are vulnerable populations in care. And so we need to have that in mind. Even when we administer surveys, for example, to measure their levels of loneliness, we use standardized psychometric scales, for example, the UCLA loneliness scale. What we see is that our participants don't want to give us a score. They want to tell us a story. And so you are there to listen to the stories, and that requires time, which sometimes we don't have as researchers. But that's really important for the quality and the trustworthiness of the qualitative data. Thank you.
Um, there's so many great questions. Unfortunately, we'll have time maybe for one more question. And I don't know if that is one that can be answered briefly because it can be a controversial topic. And that is that given that there are challenges in terms of facilitating co-design, do you think AI can play a role in this whole ideation process where you would use AI as a way to capture people's voices?
Thank you. It's such a great question. Definitely, definitely. We actually are experimenting with chatbots to engage in conversation with other people about their ideas of AI and what they want from AI. And so because we see AI as a social technical system, it's actually one of the stakeholders. Technology is for us one of the stakeholders in the room. And so we try to integrate that in the co-design process as well. That doesn't mean that we're not critical of how we use AI, but it is, of course, part of all the research that we do. And so we do integrate AI in even the co-design process in terms of prompting chatbots, asking questions, letting older people run sessions where they ask questions of AI and so on, because otherwise that engagement would be very artificial in my understanding. And so technology has to be in the room, has to have a voice somehow. And so AI is definitely used in our new projects in the sense of not only to think about the topics at hand, but also in terms of facilitating some of that engagement.
Well, there's a lot more questions that unfortunately we won't have time to get to. Maybe folks can email you directly if that's okay to continue
Of
that
course, of
conversation.
course. Please
Uh,
just send me your questions, your comments. We are also very open to learn from different experiences, different studies. And I think it's by bringing that diversity of experience that we also progress our sciences and our fields of research.
That's wonderful. Thank you again for this really thought-provoking
Thank you.
presentation. I want to thank everybody for attending. We are concluding this academic year's webinar series, and we will continue with the Web Pen AI Tech webinar back in September 2026. So stay tuned for more announcements about our lineup of speakers for next academic year's webinar. Again, Barbara, thank you so much, and thank you to
Yeah.
everybody.
Thank you so much, everybody.